Here it is. Once again, it's time to go Inside EMS. We are live from the Inside EMS studios. I think we did that a couple of weeks ago. There is no Inside EMS studios. It's just Chris and Kelly coming to you for our basements, wherever the heck we are. But Kelly Grayson, how the heck are you doing?
I'm good, man. It's starting to feel like summer up here. I love the fact that it's 85 degrees out and people go, boy, hot and muggy enough for you. So I
You
just
guys don't
laugh.
get
It's so
humidity up
cute.
there, though? Is there humidity up there?
It for a couple of days last week, it was pretty bad. It
Is
felt
it
like
really?
Louisiana. Temperature was above 90. The humidity wasn't as bad as Louisiana Gulf Coast, but it was pretty high.
Yeah, Missouri's got a little bit of Texas heat to it. I mean, I think
Yeah.
Texas is a little bit hotter, but we get some really bad humidity. We get some really good heat. So it's very, very close. I
Yeah.
remember my first summer up here coming out of Texas, and it wasn't bad, but I was able to stand it a little bit more. Everybody was dying, but
Yeah.
as you acclimate after all these years, but you know what? It's only going to get hotter. It's only going to get colder, right? But so Kelly, today, I think we've got a story, man. I think we've got a good show and one that we don't really spend a lot of time talking about it unless our good friend Peter Antevi is on. And that's when we deal with pediatric calls. But I got a quick story for you. I mean, you arrive on scene to find a 2-year-old in mom's arms, and the kid's gasping for breath, lips are pale, the room is silent, no crying, no wheezing, and just that wide-eyed look of dread. What now? And EMS, we know that trepidation of EMS providers is that pediatric call. And whether we're going to get it from a cardiac arrest, whether we're going to get it from a medical call. And you ask EMS providers, I've said this for a lot of years, Kelly, you ask EMS providers, what's that call that scares you? And they always say that it's pediatrics. And I say, as an EMS leader, if we know that that's a weakness for for our employees, what are we doing to help them make it a strength?
Yeah.
And if we're not doing to help them build that into a strength, we are just as culpable when a mother hands them a 3-month-old that's in cardiac arrest and they don't know how to handle that arrest. So I want to ask you the question: how can EMS providers build clinical confidence with one of the most feared call types, pediatric respiratory distress?
Well, first of all, I think Peter Antebi puts it really well that we do our EMS a disservice when we foster this notion that kids are different than adults. They are different than adults physiologically, but all of the things that we do in an adult cardiac arrest, we do in pediatric arrest. It's not new information, it's not new skills. So really, it's just a resuscitation. The problem that scares people so much is they don't run many of them. They don't run many cardiac arrests, period. And a tiny fraction of those are pediatrics. You can educate yourself, and that is one of the probably the lowest or the least educated we are about any call type is pediatric emergencies. It's been better in recent years and recent curricula, but still, I don't know of any provider that feels comfortable with pediatrics. So I suppose the mind game being the first one, just convince yourself that this is a resuscitation call and we handle it like any other resuscitation call. It's
Yeah.
just smaller body, but educate yourself above that, and that'll help a lot with the fear and trepidation you have.
But we're going to talk about respiratory distress in the pediatric patient today, and not necessarily pediatric arrest. But
Yeah.
one of the things that I think we have to be able to look at is that very, very quickly, respiratory distress in a pediatric patient can turn into respiratory arrest very, very quickly. And I think we've all had those calls, and I've tried very, very hard to prepare myself and to prepare my medics for them to take those pediatric calls and feel a little bit confident in them. But I do want to ask you, I mean, just before we get into the breakdown of pediatrics, was there one pediatric call that really just kind of set it apart for you to say, God, I got to do a better job?
Actually, no. Peds has always been my thing. I've loved pediatrics. I've taught PALS, hundreds and hundreds of PALS classes over the years, so that's always been kind of my thing. I think the first pediatric call I ran, I was a new paramedic working with my boss, who was a paramedic applicant. He had tested and hadn't gotten his results yet. And we arrived on the scene, and he was he was my boss, and I came in and took over and ran the call. And afterwards, he said, "You did pretty well on that." I said, "Well, thank you. don't know what I did different than I do any other ones. I said, why? You've done a lot more of these than I have. Why did you follow my lead, and why did you follow my orders? And he said, I don't know. You just had a thing. You act like you knew what you were doing. I have been on calls where other providers really freaked out because it was a pediatric patient, and I can understand how they get that shook, but it's never really been a major issue for me that I couldn't deal with. So
Yeah. So let me ask you this, Kelly. So when we think about pediatric distress, respiratory distress, I'll pose you this question. Why do kids crash differently than adults?
well, number one, kids are rate dependent on just about everything. They're rate dependent on cardiac output. They're rate dependent on respiratory arrest and respiratory compensation. Because adults, when we need to breathe more, we can breathe faster and we can breathe deeper. Our intercostal muscles will contract, spread our ribs apart, pull our sternum outward, and we can increase our tidal volume when we need to. When you're a pediatric patient, can't do that. The younger you are, the less likely, the less able you are to do that. And all that muscle work that those kids expend trying to expand their chest just causes retractions. It doesn't really expand their tidal volume all that much, so they wear out quicker. And when they wear out quickly. The only good thing I guess you can say about that is, a child's in pediatric patients in respiratory distress from the doorway. You don't have to ask a bunch of questions. You don't have to listen to a chest, really. From 10 feet away whether they're having difficulty breathing.
That's kind of what I posed in the beginning, right? I mean, those smaller airways, you got faster oxygen consumption, and you got to really know that and we used to use that. So one of the honors that I've had in my life, I think, was to be the chair of the EPC course for NEMT. And, having the opportunity to teach pediatric emergencies was really something that was helpful, and common medical emergencies was something I think really kind of gave confidence. And if you have the opportunity to take an EPC course, I would still coach you to do that, I think, as much as we can. So if we think of some of the common airways, we're talking about three areas. We're talking about upper airway, lower airway, and systemic. But in the upper airway, what are we looking for? I mean, what kind of disease common causes can cause these respiratory distresses in pediatrics?
Croup and epiglottitis and foreign body obstructions. Foreign body obstruction being far and away the most common. Epiglottitis, they all taught us about in EMT school about these kids and that they're drooling and they don't want to swallow and they're sitting with their jaw jutting forward. Don't try to visualize their airway because you'll cause laryngospasm and they'll suffocate. Really, in 2025 in a industrialized nation, you're not going to see epiglottitis.
I think I've seen maybe 5 in 35 years.
I've seen epiglottitis 4 times. Every single time was an adult.
Really?
Jim Page back in the day had an episode of epiglottitis that he wrote about in Jim's, but you just don't see that in the age of antibiotics and decent health care in the United States and other industrialized nations. You don't see epiglottitis in pediatric patients.
Yep.
Croup, on the other hand, and RSV and bronchiolitis, you see a lot of.
How about the lower airways? What are we looking for? I mean, what could cause those?
Bronchiolitis, pneumonia, and asthma. We call it lower airway disease, or the name slips my mind.
Take your time.
Or the disease of the lung tissues themselves, and pneumonia being the most common one.
Yep. And of course, we talk about systemic. We got congenital conditions. We got sepsis that we really have to be. I mean, if a kid has sepsis, we're in a bad place.
Yeah.
And we really got to do that. So if we think about the assessment now, we're going to go ahead and start to, as you mentioned, we walk in the house and we know that this kid is either sick or not sick. One of the things we teach in EPC is the kid's sick or not sick. And you're going to know that as soon as you walk in. The way they look, the way they're limp, what their eyes look like, how they're breathing, you're going to see it. But when we think about the assessment, how you approaching this, Kelly Grayson? You see this kid in mom's arms and you know that this kid is sick. What are you doing?
Well, the fact that he is limp in mom's arms, he's pale, I know right away that a little blow-by oxygen and an ebb treatment is not going to do the job. I need to take him away from mom, position him appropriately, and start ventilating, because probably the best dividing line or demarcation between compensating and decompensating in a pediatric patient is mental status. If he's gasping, cyanotic, and limp and not responding to my presence in the room, he's already tipped over into respiratory failure and he needs help. He needs oxygenation and ventilation.
Yeah, or she. One of the things that's
She, yeah,
interesting in an older kid, you could see them tripoded, but you could also
yep,
see that head bobbing too as well.
yep.
So that's one of the things that you got to watch for. And then, like you said, mental status, lethargy is light and dangerous, and of course, cyanosis and modeling. You want to do that. Now, one of the things that I've tried to teach EMTs and paramedics is how to use their stethoscope, and especially how to use their stethoscope when it comes to listening to the heart and listening to the lungs. I don't care. And I used to tell the paramedics and EMTs this all the time. Everybody that you encounter, knee pain, they've fallen on the sidewalk, you listen to their heart and you listen to their lungs. Why?
Yep.
Because you want to know what normal
Yeah,
sounds
that's
like.
right.
And if you learn normal, when you put your stethoscope on somebody's chest or in somebody's lungs and you hear something that's not normal, you may not know what it is. But when you go to the hospital and you can say, Doc, listen to their heart. I don't know what that little click is, or I don't know what that, you just taught yourself what that was. You're having the doc name it for you. But now when you start to think about listening with intent, this is one of the best skills that I think a paramedic has. One is their assessment skills, but two, their ability to use their stethoscope. How important is this?
Hugely important, and that's always been my Achilles heel until amplified stethoscopes came around. I have sometimes a hard time hearing high pitched sounds, so wheezing sometimes, especially if it's faint or if there's a lot of ambient noise around, can't hear it all that well. One thing that trips people up when they auscultate the chest of pediatric patients, a toddler and an infant, a lot of time these kids have really, really resonant tissues, and sound can transmit from one part of the airway, like an upper airway, into the lower airway. So you may be listening to what sounds like wheezes in the lower airways and the lower lung fields, and it's actually inspiratory stridor. If you happen to listen right there, you would notice it. Probably the biggest way you can tell the difference is because stridor is an inspiratory sound and wheezing usually is an expiratory sound. So you pay, if it sounds like they're wheezing, make sure to auscultate those upper fields and see if this sound is on inhalation or exhalation. The only thing worse than that really bad stridor or significant inspiratory and expiratory wheezes is hearing nothing.
Nothing, no
And
sounds. Yeah,
yeah, you can't hear anything, you got a problem. And
right.
you've got to start working very aggressively to manage it.
And I think one of the best things that were created when we start to deal with a pediatric assessment was the Pediatric Assessment Triangle, right?
Yep,
So it gave you the opportunity to think about appearance. It gave you the opportunity to think about work of breathing. It gave you the opportunity to think about the circulation of the skin.
yep.
Once this Pediatric Assessment Triangle came out, how important was that? I mean, what does this do for us in the field, Kelly?
Well, that was huge because, everyone tends to get tripped up on numbers and numbers and measures of things. How fast are they breathing? What is their heart rate? What is their cardiac rhythm? What is their blood pressure and all this kind of stuff? And when a child is critically ill, you don't need those numbers. All you need is that pediatric assessment triangle, which is a very specific look test. If the kid looks bad, they are bad, that sort of thing. And you could do from 10 feet away, because if a child is only mildly or moderately ill, the act of you assessing them and putting your hands on them and listening to their chest is just going to make everything worse.
Yeah.
So when you have the toddler who naturally has some stranger and separation anxiety and is scared of other people when they're very stressed, all you of listening to their chest is going to do is you're going to hear a bunch of screaming. You palpate their pulse and you're going to feel tachycardia because they're upset. So that PAT is especially useful to minimize your initial interaction with the child so you get a better idea of their baseline. Plus, it's just a great way of telling not only how critically ill this child is, but what organ system is causing the problem. If you know how to use that PAT, you can tell if they're in respiratory distress
Yeah.
or respiratory failure, compensated or decompensated
I think
shock, or a
that's an
neurological
important thing.
problem.
I want to cut you off there because I don't want you
Yeah.
to get too deep in that. How why is that? Why is that something that's going to give you that best, the best opportunity to understand that? So you said you get to know what body system. How are you going to figure that out using the PAT?
Well, if you look at appearance, breathing work, and circulation of skin, appearance is first going to tell you compensated or decompensated. If they are behaving normally as a child of whatever age you would expect to act, then that's normal appearance, and they're still compensating at that point. You bare their chest and look at their work of breathing from across the room. Are they head bobbing, as you mentioned? Do they have nasal flaring? Do they have retractions or grunting? Grunting is just auto peep. They're trying to trap a little air in their respiratory tract to keep their alveoli open. This increased work of breathing is going to tell you whether if it's increased work of breathing, it's a respiratory problem. Okay, increased work of breathing plus normal appearance, respiratory distress. Decreased work of breathing or increased work of breathing and abnormal appearance, respiratory failure. Same way, if the patient is shocky, they're going to have poor circulation of the skin. Cap refill will be delayed, they'll be mottled, they'll be cold to touch. In shock, you're going to breathe fast, but it will almost always be effortless tachypnea. They'll be tachypnic, but their work of breathing will be normal. So you can tell if the patient is in decompensated or compensated shock. And if none of those things apply, work of breathing is normal, circulation of the skin is normal, yet their appearance is altered, it is some type of metabolic or neurologic problem, and you start working on it from there.
Yeah, I think that was a great overview, and I think that's perfect. So one of the things that you said is, you have a kid and you said, I know that blow-by isn't going to work. Let's talk about some of these treatment priorities. Let's talk about some of these pitfalls. So even though you have a kid that's in respiratory distress, you know that they're sick, you've now moved them to the back of the ambulance because you want to get to the hospital as quickly as you can because you don't know how fast they're going up that mountain. And as soon as they get to the top, they are going to crash and they are going to crash hard. Yeah. But we still don't want to skip the basics.
Yeah.
So give us a little bit about that.
The basics are the thing that is going to save the kid's life. You can take any ALS intervention we do, and there's precious little proof that it's actually beneficial. But the BLS stuff is what's going to save this child's life. High flow oxygen, BVM support if necessary, if they're showing signs of fatigue or they're pretty tight and their tidal volume is
poor. Hang on a second.
Positioning.
Let's talk about that, the BVM, right? Because it's one of the things it's one of the things now when you start to talk about using a BVM in a basic skill that gives the paramedics a little bit more anxiety and a little bit nerve. Just talk about the best way to handle a pediatric patient with a BVM.
Well, in general, anytime you're picking up a BVM, period, adult or pediatric patient, it's a two-handed procedure, a two-person procedure. One person holds the mask seal. You put the child in sniffing position. You don't tilt their head back, face parallel with the ceiling, ear canal lined up with their sternum, and you gently breathe. One person squeezes the bag. And the overwhelming tendency when someone does BVM ventilation on anybody, but most especially a pediatric patient, is they breathe too darn fast. American Heart Association has been taught us for our entire careers that 20 breaths a minute is what it's supposed to be, and that is true. You don't need to breathe 30, 40, 50 times a minute for a pediatric patient. Give good breaths, 20 breaths a minute, high flow oxygen, make sure their airway is open. And if you're meeting resistance to that, there's your bronchodilators come in. Make sure they're positioned appropriately and give some inline bronchodilators like albuterol and ipratropium bromide or Zopanex,
right.
And that'll help open that child up. The other thing is some of these children, particularly the youngest ones with significant lung disease or preemies with hypoplastic lung disease, have tight little lungs. So you do need to know how to disable the pop-off valve on your BVM.
That's a great point. That's a great point.
In a pediatric patient. You won't always have to do this. In fact, most of the times you won't have to do this. But in the sickest kids, sometimes you need a little more pressure with that BVM than the safety feature will allow. You also have to remind yourself that when you disable the pop-off valve, you have just turned off the safety feature of that BVM, and you need to act accordingly. Don't go crazy.
And one of the things to always remember is suction is another big basic skill that we have to be able to think about. And another one that gives people, trepidation. If pediatric arrest gives people trepidation, we start to do BVM, we start to do suctioning of a pediatric patient, it's really going to increase the pucker factor times 10. You already talked about some of the common medications. Yeah. I want to touch on you, and maybe you don't have this, because I'm a little bit blurry here as well, but you have a little bit more field experience, more current field experience than I do. Nebulized epi for croup. What are you saying?
Yeah, we use nebulized racemic epinephrine for croup. It's in our protocols up here. We carry it on the ambulance. Oddly enough, this is the first time I've carried in any agency I work for nebulized racemic epinephrine. But it's fairly simple. You put the
any other nebulizer, yeah.
Yeah, you sit up and ebb,
But I've never used it. I've never used it in all my years.
it's I haven't had to use it up here other than in simulations to check off competency. In fact, I did one on the 26th. I had to do a simulated pediatric code and give racemic epinephrine. It's the doctors up here seem to like it. In back where I worked in Louisiana, we could give racemic epinephrine. You just give the appropriate amount of epinephrine in a
Nebulizer.
nebulizer,
Yeah,
but we didn't carry specifically formulated racemic epinephrine or the ampules for it.
very cool. How about some of the pitfalls when it comes to treatment priorities?
You first of all, your best tools for assessing this patient are your eyes and ears and hands. Don't fall into the trap of being over reliant on technology. Okay, this is one of the when I teach PALS classes, the biggest mistakes, most common mistakes made by people who are not pediatric centered, like get an ICU nurse in a PALS class, and they're going to say, "What's the heart rhythm? What's the blood pressure? What's the pulse ox reading?" And all that stuff only shows you only something significant when the kid has already run off the end of that cliff. Experienced peds nurses and experienced paramedics with peds ask, what's he look like? What's he feel like? They don't care about a pulse ox reading. They care about the effectiveness of the child's mechanics of breathing. The dehydration is going to make the child breathe faster. Dehydration is nothing but compensated shock when you think about it.
That's a
You're
good
going to
point.
be
Yeah.
tachypnic. So what?
I said that's a good point.
Yeah, that's it. It's volume depletion that your body can deal with right now. That's nothing but compensated shock. You're going to be tachypnic in compensated shock, but it'll be usually an effortless tachypnea. I don't think you can wait too long. I mean, I don't think you can react too quickly when the child shows significant signs of respiratory distress.
I agree.
The BVM police are not going to come take your card away
That's
if you
right.
start bagging the baby earlier than someone else would have.
But you got to
You're
feel
not going to make
comfortable
them.
enough to do it. You got to feel comfortable enough to do it.
That's
And here's
right.
another
That's
one
right.
that I've always talked about, thinking that crying equals stable. Now, we know that if the kid's sick, they may not be very, very active. But just because a kid is crying, don't fall into that tunnel vision of thinking, okay, the kid's crying, the kid's okay. Because again, you've got decompensation relatively quickly. Let's see. Let me give you a scenario. How are you going to
All right.
handle this? How are you going to handle this? So you've
Okay.
got a 3-year-old with respiratory stridor. Let's give them a barking cough. You look at the SpO2, they're at 90%. They're sitting upright. They're a little anxious. I'm going to give you vital signs of a heart rate of about 160, respiratory rate of 50,
Okay.
and the extremities are cold. What are you thinking?
Okay. I'm thinking that this child has croup or some other type of upper respiratory infection. That barking cough is a dead giveaway. A child he does have cool extremities. That may just be sympathetic compensation. He has to breathe fast. His sympathetic nervous system is going to kick in. That might be causing the cool extremities. First, I'm going to start working on the breathing problem. I'm going to give him high flow oxygen, racemic epinephrine. He's sitting upright right now, so he's still compensating. He's anxious. You'd expect him to be. Yeah, I'm going to start with the racemic epinephrine and trying to open up that upper airway a little bit, try to reverse some of that stridor. And if that doesn't work, I'm probably going to think about other options and other causes. But I'm leaning really hard toward an upper respiratory infection or a croup, something like those lines.
Yeah, I think that's good. So let me give you my closing thoughts, and then I'll let you give your closing thoughts. I mean, we got 20 minutes here, right? We got 30
Yeah.
minutes here. I think we gave you some really good guidance. What I would do is I would listen to this show. I would go back and listen to it again and take notes on everything Kelly told you to do, right? He gave you some really great guidance on it. Then after that, I want you to really go back and read exactly what we were talking about when it comes to assessment, when it comes to using your tools, when it comes to listening to the chest, when it comes to listening. I mean, here's the truth, right? When you think about pediatric calls, it'll always stir something deep in you, right? It does to us, and we're experienced in it, right? You may be a new paramedic. This
Yeah.
is not just about a clinical challenge, but it's a fear of getting something wrong. You got a mom, you got a dad, they're begging you to take care of their kid, right? It may feel impossible, but don't fear it. You've got to
Yeah.
be able to think, you've got to be able to treat, and you're going to find yourself in a second nature, right? You're eventually going to get there. Every time you walk into a room with a sick or struggling child,
Yeah.
you bring more than a kit and bag. You bring calm to the chaos. You bring presence to the panic. You bring hope to the people who's living their worst moment. So here's something that you need to remember. You don't know everything, but
Yeah.
you do know to slow down, trust the basics, and act early. Kelly, what do you give people for your final thought?
I think your number one weapon is preparation. If you feel weak in pediatrics and is uncomfortable, take a PEP course, take a PALS course. PEP probably better for pre-hospital care. Take an EPC course, even better. Almost all of these can be summed up as airway, 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 100% oxygen, 20 cc's per kilogram fluid bolus, keep them warm. Hey, did you check that airway? And get them to the hospital quick. But they're going to give you the tools to assess this pediatric patient and know how to treat them. Secondly, prep your equipment. It's a lot easier to run through a stressful call if you know where everything is and everything is set up for that particular patient. It's a good investment to set up a pediatric kit and your cheat sheets. By all means, use your cheat sheets. Don't try to memorize drug dosages. Look them up if necessary, or use a hands-heavy card that's going to tell you well before you even get to the patient roughly what kind of equipment sizing and medication doses you're going to need. And above all, breathe. It's not your emergency, so somebody has to remain calm. If you're not calm, just fake it till you make it, because remember, you're bringing that calm into the door for the family.
Give them the close. Let's go to close and get out of here.
Yeah. Well, you've heard what we think about pediatric emergencies. Pediatric calls always going to scare us a little bit. And the next time that room goes quiet, your trainer is going to speak louder than your fear. So remember that. And thanks for tuning in to Inside EMS. Don't forget to rate us on iTunes, and we'll catch you guys next week.